We've already received a number of questions, but I would encourage the audience to please type in questions as you think of them. But why don't we start with some of the questions we've received. The first is, why would you even consider a test that looks at only part of an organ, meaning the flexible sigmoidoscopy? Why does that persist as an option?
Well, the reason, that's a very good question. And it's a question that has been asked many times a while ago. And in fact, at one point, it reminds me of a joke that someone made. It's like, oh, it's like doing mammogram on one breast only. The reality is that, looking back, that's not entirely correct. Number one, there was a thought that we had more cancers presenting or occurring in the left side of the colon, so the lower half of the colon, if you want, than proximally. That's no longer the case. But importantly, this whole notion of a sentinel lesion. So you might have a proximal cancer, but you would have polyps further down. We know that doesn't hold perfectly true. But the reason why we still are considering it's very much is based on the evidence. As you look at the numbers for how flexible sigmoidoscopy has performed and how colonoscopy has performed, even though intuitively you would say colonoscopy is better, and I'm a gastroenterologist, I do colonoscopy, I hold it dear and near. However, I have to accept the fact that the evidence has not been excellent to say that, to support that. We have not made substantial improvements in colorectal cancer mortality reduction with colonoscopy compared to flexible sigmoidoscopy. We now have randomized trials for flexible sigmoidoscopy. We don't have them for colonoscopy. I might be able to give you a different answer in a few years, but right now, the evidence would still support using flexible sigmoidoscopy. And again, this is just in terms of the effectiveness piece. The other piece is the cost. The cost of colonoscopy is higher than the cost of flexible sigmoidoscopy. So if you're looking at the cost effectiveness, it holds correct at this point that the cost effectiveness is not that different.
That reminds me, when you're talking about cost of colonoscopy, in the newspapers a while ago, there was great controversy about the huge variability of cost for colonoscopy across the country. And as we talk about evidence and maximizing use of healthcare dollars, what can we do to standardize procedures and costs? Do you have any feelings about that? How do we address the concerns that were raised? And when, in addition, when costs in the U.S. were compared to other countries, there was really quite a substantial difference.
Yeah, costs, charges, all kinds of things that are a little, I cannot comment directly on individual providers or hospitals or whatever. The direct cost of the procedure, they do require facility, there's a room, there's a provider, time, there's all that. They clearly vary a lot. I will start first actually addressing the quality piece because it's not occurring in the vacuum, but the quality measures for colonoscopy, those have received a lot of attention. So having a good quality, high quality procedure is very important to ensure that it truly is protective. And that gets at the point that I was making before, the metrics that we currently have, and they're fairly well accepted. And I believe those will become more publicly available for people to judge and see, compare potentially across providers, across institutions. Do these institutions, are they doing quality, good quality procedures? As far as the costs, they vary widely. To speak outside of the US, for example, sedation is commonly used in the US. That is not true necessarily in other parts of the world. Sedation, colonoscopy can be performed without sedation by patient choice, for example. Periodically that happens, but largely in the US is performed sometimes even with monitored anesthesia care, which increases the cost. Typically with moderate sedation, which increases the cost but not as much. And without sedation would reduce the cost further. But in the US, it's still considered to be done with sedation. That can address part of the issue why it's less costly in other parts of the world. I don't know beyond that in terms of how institutions assess how they actually allocate the costs and their charges. I agree it's a problem, and it becomes a real issue when you're trying to do cost effectiveness models, and you have to use a sensitivity analysis to say, in my neighborhood, in my geographic area, does the cost of colonoscopy go up or down compared to what's used as an assumption in that model? And if it goes down, it's going to make it more cost effective. If it goes up, less cost effective. Unfortunately, I don't think I can say much more than that.
Well, thanks. Another question is, and certainly we hear about this all the time, is can you speak to the issue of bowel prep or inadequate bowel prep? I find that most patients dread the prep more than the actual procedure, and I get a lot of reports which say poor prep. Do you have any suggestions how to improve the prep and tolerability?
I wish I had better, but I'll tell you that we have actually improved our prep in the last few years. Yes, I think it's correct. A lot of patients will tell me the procedure was not bad at all, the prep, terrible. The prep we currently use, and the one I'm favoring, and I think that a lot of people have moved to that prep, is called a split prep. It's a prep that is taken half in one allotment and another half another, typically half the night before, half the day of the procedure, which means if a patient has like a 9 a.m. procedure, they have to get up in the middle of the night to drink the prep and complete it, which is, an inconvenience, but actually works very well. So the split prep seems to be better tolerated and lead to better quality of the exam, which is important. So patient adherence to prep is important, and I agree that the easier the prep, the better off we are. I do tell my patients, however, that it's going to be an unavoidable fact that they are cleansing their colon, and there's only one way it's going to be cleansed. It's going to have to be achieved. I don't know if there's anything currently available that would be less unpleasant than taking the split prep at this point. Other preps have come and gone. They've been found to have, especially with more risk, have fallen out of favor. The limitation of the fair prep is or poor prep is a really good one. As you can imagine, one cannot say, I examined the colon entirely and I'm comfortable that I'm preventing colorectal cancer in this person if you don't have a good prep, and especially now they recognize the prevalence of those flat polyps that are hard to see unless the colon is very clean. So the bottom line is, I would encourage your patients to do the best they can with the prep. There are certain patients, we don't know who they are up front, although people who have constipation, people who have diabetes may have decreased motility of the colon. There are certain individuals who may benefit from a 2-day prep. Again, not the most fun thing, but patients are given instructions for clear liquids, not for 1, but for 2 days. And sometimes they have to actually use a 2-day prep, meaning 2 days worth of prep plus prep again. Unfortunately, that's often found after you failed a prep, after you come in for your procedure, not prepped enough, reschedule, do a 2-day prep, move on. It's the reality of what we have currently. I don't think I have any other great answers to that concern.
When people talk about a miss rate in terms of polyps and perhaps cancers up to 25%, do you think it more falls in the range of that people have poor prep, or is it more the actual endoscopists?
I think it's a mix of both. I do think well, for one thing, we have better optics now. We have high definition imaging, so we're seeing things that we probably did not see before. We do expect better cleansing because we know we're going to be able to see more, or we're going to miss things if there's not. So we are more willing to say, abort, come back. At least I am, and I think I'm not alone in that. We are much less willing to say, fair prep, okay, come back, we'll deal with that. We are a little more strict on what we think it's a good prep. I do think we are more able to see things both because of how we've been trained, what we are alerted to see. The miss rate, I don't think it's going to be in those numbers if we count only the ones that have a good prep. But the reality is that, and we've known this all along, that the recommendations for screening in terms of the intervals for colonoscopy, for example, have only applied under the assumption of a good prep. So once that assumption is not met, then the the next step then does not follow. And I realize that our patients will never get a wonderful prep no matter how much effort we put in, but that really should be a really distinct minority. For most patients, we should strive for an excellent prep so we can get an excellent exam and can give them the full follow-up interval.
There's a question, and I've certainly heard this before. Is home fecal occult blood testing as reliable, effective as that done in the office? I have patients who tell me they tested positive when they did it themselves at home, but when I repeat in the office, I get a negative result. Is sending the patient for colonoscopy based on a positive home result appropriate?
Absolutely. In fact, I could not emphasize that more. Any positive test from a fecal occult blood test, unless for some reason you think the patient has a reason why he's having like overt hemorrhoidal bleeding, which would lead to an evaluation, not for screening, but a positive test to be able to be utilized appropriately is followed by a full colon exam, a positive fecal occult blood test. That's how the data has been derived from the large multi-randomized studies. So you cannot expect efficacy of FOBT screening unless you truly follow through with the testing. The digital rectal exam or still obtained digital rectal exam testing has never been tested, has never been recommended, and I would strongly advise against that. The one type of testing for fecal occult blood that is recommended as a screening is indeed the one done at home. And currently we have those two options, the FIT, which has gained favor because of its higher sensitivity and without really loss of specificity, versus the high sensitive guaiac. The low sensitive guaiac are no longer even recommended, period. Once someone has a positive fecal occult blood test at home, there's no need to repeat it. There's no value in repeating it because you really are not going to change your management by repeating it. Studies have shown that it's done, and it can be tempting, but I would strongly advise against.
This is related, and I suspect perhaps you would agree with this. It says, why not advise patients to self-perform annual fecal occult blood testing and bring the result in to reduce the burden on primary care? And also ask, what is the validity of the over-the-counter stool testing kits that are available?
I'll answer that one first. So those have not been, those over-the-counter tests have not been evaluated the same way in terms of trials as the FIT and Hemoccult. I'm using the brand name Hemoccult, but I mean the fecal occult guaiac-based high sensitivity test. So I would not be able to comment on those. I would not recommend them as part of a primary care or medical provider screening strategies for your average risk patients. Yes, the idea of doing the annual consistent exam is key to achieve the numbers that the studies have achieved. The actual way of ensuring the patient does the annual test, I can elaborate more about that in terms of certain populations, but currently it falls on the provider. Yes, you could say the same way you do other tests, but it's no different than getting your women patients to do a mammogram on a yearly basis, for example. It would fall on the provider, and I would argue that these days, especially with the use of electronic medical records, one has the ability to create flags, to create mechanisms by which the provider will see the patient and realize that they are up for their annual fecal occult blood test screening. There's other methods of reaching people, and again, in certain studies that I've been involved in, reaching more underserved populations, there are stronger messages that include, for example, things mailed to the patient's home, phone or text messages reminding them it's time to complete your annual screening, encouragement, even to the point, if they fail those different steps, to the point of a navigator, so to speak, a reminder person that calls the individual patient to remind him or her to complete.
And actually related to that, we got a question from a nurse who says, how can nursing help to increase adherence to screening?
Key, very important. When I mentioned the provider recommendation, it does not even have to be a physician. It can be a nurse practitioner, and can definitely be an integrated practice in an office to have the nurse be the one that, after the provider, nurse practitioner, or physician has made the recommendation, and the patient has opted to say, okay, I'm going to do a colonoscopy, or I'm going to do a fecal occult blood test. The nurse can reiterate the importance, can review prep concerns, can review preparation of the stool samples, can review need to return it on a timely basis, can definitely do a lot in terms of the education of the patient at that point, absolutely. And then the following up, the same thing. The patient has a positive stool test, the provider knows about that, the patient gets notified of the positive stool test, and then what? If the recommendation is not made for colonoscopy and someone is not ensuring that colonoscopy gets scheduled and completed, then we really have done nothing for that patient. The positive stool test in itself has no value unless it's followed up by the full colon exam.
Yeah, I've actually heard offices, and perhaps this is under the direction of the nurses, where when people have their 50th birthday, it triggers a message, and people are reminded to begin their screening process.
Absolutely, and the same can be, I mean, flags can be put in those, in our, most people would say, probably have electronic medical records these days. They allow for that kind of tailoring of triggering a flag. If you do a fecal occult blood test, it's negative today, then on January 30th next year, a little thing will go up, and if the patient comes in for an office visit, say right before, right after, you'll be able to see, oh, when is your last one? You up for next month or next year, whatever. And the same thing with colonoscopy. If it's a negative one, then you can make it a flag for 10 years later.
Also, there are increasing reports that younger people are now being diagnosed more and more with colorectal cancer. Have people begun to address how we deal with a younger population in screening? And these are people under age 50. Of course, some of them may have a family history, but when should we start talking about colorectal cancer now, and how do we address a rising incidence of younger patients?
So a couple of things there. Definitely the family history piece would apply for anybody, even younger patients, obviously. But just going to the incidence, we are seeing certain increases. There's one group among African Americans, not all the societies, but at least one society has recommended starting potentially at age 45 screening among African Americans because of the concern, exactly that, of an incidence of colon cancer at a younger age. We haven't seen the national numbers really shift much yet. We may. We have seen a shift from left to a bit more of right colon cancers that may be a product of increased screening, or more of the higher risk polyps in the right side of the colon, or possibly a combination of all kinds of factors, environmental factors, not clear, but that has been raised. We currently still do the 50-year mark as the starting of screening, and we may change if the evidence supports that. The family history piece, I think it's a very important one. Family histories are dynamic, for one thing. What's true for you when you are 30 years old, next month may not be, because now your father, your mother was diagnosed with colon cancer. So I would recommend that people get a family history when they are established care with a primary care doctor, but then on a yearly or every couple of year basis, they update their family history and they bring back to their doctor new issues occurring in their family. Not asking about family history means you know nothing about it, and just asking a generic, do you have any problems in your family, doesn't help very much. My personal approach, and again, I also deal with some of the high-risk patients as well, the genetic syndromes, is to go first relative by relative, and ask about age, medical issues, or cause of death of mother, father, siblings, and then extending that depending on the patient's history. If you start finding multiple relatives with cancer, that should definitely be a red flag for a much more fuller family history. Similarly, if a patient comes to you and say, oh, I need to be evaluated because my dad had colon cancer at a very young age, that should also trigger a much broader assessment of family history. And for those that fall into that group, then a dedicated center that focuses on high-risk patients would potentially be the next step to allow for genetic testing, genetic counseling, genetic testing, because those patients have a very different approach to screening.